Good afternoon. So I have the pleasure of presenting some of the results from PERCH. And PERCH was a case control study of hospitalized pneumonia among infants 1 month to 59 months of age. So it does not include the neonates, which were accounted for in a separate study. This was in 7 countries and 9 sites and aimed to really improve the evidence base for pneumonia prevention and treatment. And I really first want to acknowledge the 7 principal investigators from the sites and an enormous number of collaborating institutions who got together to undertake this study. So in this talk, I want to just briefly talk about the PERCH study description, the study design, and then the descriptive epidemiology of the RSV cases, and finally, some brief comments about the contribution of RSV to pneumonia etiology. So for those of you who are not familiar with PERCH, it is a case control study. The cases were 28 days to 59 months and had to be admitted to hospital. That was the entry criteria, with either WHO severe or very severe pneumonia using the pre-2013 definitions. And you see here the criteria for those definitions. Controls were children enrolled from their homes who lived in the same catchment area as the cases, and they were frequency matched by age. They certainly could have respiratory signs or symptoms, but they could not meet the case definition for enrollment in PERCH. And these are the 7 countries that participated. So in Africa, it was Mali and the Gambia and West Africa, South Africa, Zambia, and Kenya. And in South Asia, it was Bangladesh and Thailand. Enrollment took place between 2011 and 2014, and each site enrolled for a 24-month period. They were not necessarily simultaneous 24-month periods. And ultimately, there were over 4,000 cases and 5,000 controls enrolled. The sites were intentionally selected to represent the situation where PCV and Hib vaccine were in routine use. This was not fully accomplished. In Bangladesh, PCV was only introduced after PERCH was ended, and in Thailand, neither of the vaccines were in the routine immunization program. With respect to the specimens and the microbial testing specifically for RSV, cases had all of these body fluids collected. And these body fluids were tested for a large number of pathogens, including by culture and by PCR. The controls had 3 of the same body fluids collected: blood, NPOP, and urine, and those were tested for a similar set of assays. Specifically for RSV, it's these 4 body fluids that were tested: NPOP, induced sputum, lung aspirates, and pleural fluid, obviously the last 2 in selected cases. The detection of RSV was by a multiplex PCR, and the target was both for RSV-A and RSV-B. So here's just a table summarizing the information on the cases and on the controls. So with respect to the descriptive epidemiology, this is the frequency, the proportion of all of the PERCH cases that are by age and by RSV and status, either positive or negative. So RSV positives are shown in red. And you can see a clear distribution of the prevalence of RSV test positive cases in the youngest infants. There was a disproportionate representation of RSV in these youngest infants compared with the proportion of cases who were enrolled at that age. One question came up was the utility of the induced sputum. And here you just see a comparison by age of what body fluid specimen it was that the RSV was tested positive from. Only a very small proportion of the cases shown in the light pink at the top of each bar were positive only in the induced sputum. So it did contribute a small amount, but largely these were test positive in the NP specimen. The RSV detection varied by age and site, and here you see age strata by the site of testing and of case enrollment. So we can see that in every single site, obviously the youngest age group was the age group with the highest frequency that was RSV test positive, with reductions by age strata that varied across the sites. The RSV prevalence also varied by severity, comparing severe pneumonia and very severe pneumonia cases, more commonly identified in those children who met the case definition for severe pneumonia, but was very common in both strata. With respect to risk factors for RSV, we looked at common risk factors and found them virtually equally prevalent among those children who tested positive for RSV and those who tested negative for RSV. There were not many distinguishing features. To move on to the clinical findings and amplify the point that was made in the previous talk and questions, the clinical findings by RSV status really did not vary according to whether the child had RSV infection or did not. So here we see days of cough, wheezing, observed fever or history of fever, and inability to feed. So less than 50% presented with wheeze. Certainly less than a quarter of them presented with observed fever, although a large number had a history of fever. In looking at the respiratory findings, again, the emphasis on hypoxia, there was a somewhat increased proportion of children who tested RSV positive who had hypoxia by oxygen saturation, but no other major distinguishing features between those who had RSV and those who didn't. Wheeze, I'd like to point out particularly, again, an equivalent number in those with and without RSV, and less than 50% in both categories. The chest x-ray findings were particularly interesting. Although all these children were diagnosed with severe, very severe pneumonia, regardless of their RSV status, about 40 to 50% of them almost had a normal chest x-ray. I wanted to mention seasonality. This has been a large topic of conversation about different parts of the world. And here you see the distribution by severe and very severe cases with respect to the African sites on this slide, and I'll show you the Asian sites on the next slide. So some of these sites you can see a clear seasonal peak, and others there is a seasonal peak, but there's RSV much more year-round, and South Africa is an example of that. And here in the two Asian sites, a much clearer seasonality of the distribution of RSV cases. With respect to case fatality, I first want to anchor the comments about RSV case fatality in the all-cause case fatality. Here you see case fatality by study site, according to severe cases in blue and very severe in red. The most important thing to note about this is the tremendous variability of case fatality across the study sites, even when controlling for the severity of disease. And the second thing is that those who are diagnosed with very severe disease do have a higher case fatality rate than those who are diagnosed with the case definition of severe illness. Moving on to a specific slide on RSV case fatality, you can see that when comparing those children who were infected with RSV with those who were RSV negative, there was about a 2.6% case fatality rate in the RSV positives compared with a 9.4% case fatality rate in the RSV negatives across all of the sites. When looking by age, again, we see the very notable difference in the case fatality by age, especially for those who are RSV negative, and a much more even case fatality ratio among those who are RSV positive. And by severity status, again, the RSV positives and the RSV negatives, a lower case fatality rate for the RSV positives, regardless of whether they met the case definition for severe or very severe pneumonia. Among all of the children who died in the PERCH study, almost 9% of them tested positive for RSV, and you can see that that was most common among the children 1 to 5 months of age and less common among those children who were older than 6 months of age. So just to end, I want to speak briefly about the contribution of RSV to pneumonia etiology. This was not a study specifically about RSV. It was about more than 33 target pathogens and trying to articulate that distribution. We enrolled controls, and I want to show you the case and control prevalence of RSV, now making comparisons across the age strata. And you can see that the RSV is present in controls, but with a very low rate. We did enroll children who had respiratory infections as controls, and you can see that there was a higher proportion who were RSV infected among those who had some respiratory tract illness compared to those who were perfectly healthy. When we looked at the odds ratio, though, of RSV status to predict pneumonia case status, RSV has a very high odds ratio and the highest among all of the pathogens that we tested. So integrating this all into an analysis of etiology, we have a different method for doing this than the usual attributable fraction method. This was an integrated method that combines body fluid specimens, not only the NP specimens, but also the blood culture specimens, accounts for the sensitivity and specificity of all of the assays, and gives you a pneumonia etiology fraction in the population, as well as an etiologic histogram at the individual case level. So I'll just end by showing you two slides which highlight site by site the pathogens and their distribution. And this is RSV. It's the most common pathogen. Here I'm showing you just in the chest x-ray positive severe cases, less than a year of age, but across all of the sites, except for the Gambia where there was a parainfluenza outbreak, the most common pathogen. And this is another slide that just shows you when you distinguish according to seasonality or age, the model and the integration of all this data does give you what you expect, which is that in the high RSV season, in the under ones, there's a much higher contribution of RSV than in the under ones who are out of RSV season. So in summary, my last slide then is just that RSV in the PERCH study was the most common pathogen identified among both the severe and the very severe pneumonia cases. Very uncommonly identified in controls, leading to a very high odds ratio for pneumonia case status. The contribution to the etiologic ply is highly dependent on both season and the age strata, so it's difficult to talk about sort of summary measures. But in spite of the frequency of the case status, the case fatality rate is low, contributing less than 10% to the pneumonia deaths. However, the greatest burden is in those very youngest children, the 1 to 5 month olds. The risk factors, the clinical data, the chest x-rays really don't distinguish RSV positive and negative children and should probably not be used as a defining feature. And documented fever, hypoxia, and wheezing are certainly present in these RSV cases as we would expect, but in less than 50% of them. So I'd like to just acknowledge the study teams and many people on the core team who contributed both to the collection of data and to the analyses, and particularly Amanda Driscoll, who did most of these analyses. Thank you.
Okay, beautiful study. And I was wondering, did y'all find out what was the cause of mortality for the RSV? Was it the virus? Was it secondary bacterial infection or something else?
So I think what you're asking about is among the children who died, what does the etiology distribution look like? There are a small number of children who had a minimally invasive autopsy done, and so we have more specific pathogen, tissue-specific pathogen information on those. But for the majority of children, we have the specimens that were collected in the pre-mortem state. We are undertaking analyses that look at the multi-pathogen analysis, which is a very difficult analysis to derive learnings from. What I can say is that when you look specifically at RSV, the contribution of multiple pathogens to the RSV-infected children is much lower than the contribution of multiple pathogens to some of the other causes. So we don't have a specific question to your answer, but we hope that future analyses may shed some light on that.
Were histopathology obtained or? Okay.
Yes, on those children who had minimally invasive autopsies of the lung, yes, histopathology was obtained and all of the microbiologic assays were done on those children. It's not straightforward, the answers that you get from that. Most children have 2 or 3 pathogens identified from their lungs.
Bonnie Graham.
Some of the early studies of RSV and HIV-infected babies, there was prolonged shedding of the virus for sometimes over 200 days. And in South Africa, where we just heard 11% are infected, do you know if that finding is still upheld in the newer cases? And if so, has it changed the epidemiology of RSV to make it more continuous?
So this study certainly can't answer that question. This is, an observational study with a single observation at the time of admission of the children. But I think the importance of the inclusion of the controls in the analysis is quite key for RSV. And given the low prevalence of RSV finding in the controls, we're at least accounting for the potential and possibility that some of these cases are in fact not related to RSV, but may just have prolonged shedding that's being identified opportunistically at the time of their pneumonia admission for something else. So I think the study design has accounted for that a little bit, but given that it's not a longitudinal study, we can't address your specific question, Barney.
Bonnie, just to answer, you may hear the answer in a couple of presentations after this. James.
Kate, I'm just wondering whether RSV is the only respiratory virus pathogen we really need to worry about in that case.
So, no, I don't think so. I think there would be hell to pay if I said something like that. I don't think it's the only viral pathogen, but it certainly is the dominant viral pathogen, at least in this large study that we did across 7 countries. So I think it's where the attention needs to be placed, albeit the fatality of those infections is not as high as is seen for some other pathogens.
So, Kate, just one question. So the case fatality ratio is low, but the overall number is large. So I didn't see, you had so much data, but your last slide summarized that 10% of the deaths were due to RSV. Is that correct?
10% of the deaths were infected with RSV.
RSV.
Whether they're attributable to RSV is a
Right.
different question,
Right.
but yes.
Right. Okay. I'm sorry, time's up. Okay. I'll ask a question, but,
One more
but I
quick
don't
one.
want to go on.
Just following up on the previous question, have you done any direct comparisons of RSV and flu?
Yes, we've done an analysis of flu. I can just tell you quite briefly that the proportion of pneumonia cases that were infected with flu was about 3%. And I won't comment on all the other analyses that then attribute etiology to flu or not flu, but it was very uncommonly found in the PERCH study.
Great, thanks.